Thank you, Professor Black, and good afternoon. I would like to thank the organization of this conference for giving us the opportunity to explain the work that has been done in the last 2 years in Catalonia on MSDs, on musculoskeletal disease, by the Ministry of Health. And let's get started. As many of you know, Catalonia is an autonomous community in the northeastern Spain. Today, population is around 7.5 million, and the Spanish health system is fully decentralized. So the competencies in health policy and the responsibility of health is of the government of Catalonia and developed through the Ministry of Health of Catalonia. This is responsible for health planning and purchasing of health services provided throughout the territory owned by public or private healthcare providers. Currently, decentralization in decision-making is promoted through the creation of county health governments, which are represented in different colors in the map, which correspond to territories having a reference hospital. The Catalan health system is gatekeeping oriented, where primary care plays a major role. So what is a master plan? So master plan are a planning tool for a specific analysis on population health and service provision in relation to a group of prevalent or relevant diseases, in our case, MSDs, and for the definition of the criteria for planning for the coming years. Measures proposed come to the territory partly to the, per case to providers, So the results obtained from the proposals are assessed by the master plan. Oh, sorry. Now, some 3 slides about the chronic health problems in Catalonia. The health survey of Catalonia allows us to gather Catalan population health problems as well as aspects related to their quality of life and relationship with health services. In 2006, the last edition of this survey was made, and about 16,000 people were interviewed, representing the total population of Catalonia. As you see in this graph, musculoskeletal disease are the most frequent chronic disease reported by the population. The first, low back pain; second, cervical pain; and the third, the group osteoarthritis, arthritis, or some other kinds of rheumatism. All these groups are more common in women than in men. Its prevalence increases with age, so that over 65 years, half of women will suffer back pain, and 3 in 4 will have any kind of joint problem. These diseases are also responsible for causing the greatest impact upon physical and mental quality of life and functional capacity of people. Furthermore, a strong social gradient is found, with highest prevalence in lower social classes and lower educational levels. Moreover, overall, this group of diseases are the ones that cause the greatest impact on functional ability of individuals. As an example, the people that refer suffering from back pain report some degree of chronic activity restriction in the last 12 months. And 1 in 4 people who report activity restriction due to a chronic disease considered an MSD as the cause, and this occurs not only in older people, but in younger and middle-aged people too, so in the working population too. As a consequence of that, you can see in this graph the causes of sick leave in Catalonia. MSDs are the second cause of number of episodes of sick leave, but the first in the lost working days. 28% of work lost in days in Catalonia are related to MSDs. So from this analysis of the situation, master plan defined some general objectives that were later worked on through strategic lines and working groups. Then the results are worked in these groups, and there come some actions to implement. This plan is now at the stage of the results. So proposals of the working groups have been accepted and will have to be implemented in the coming years. Master plan has prioritized 6 lines of work in relation to prevalent or several clinical processes: low back pain, osteoarthritis, osteoporosis, rheumatoid arthritis or chronic arthritis, soft tissue rheumatism, and fibromyalgia. In each of these lines, working groups have been constituted that have finally made some proposals to improvement. These proposals can be grouped in 6 topics: improving the patient self-care, the training of professionals, the involvement of nurses, especially in the primary health care, the better use of new information and communication technologies, the intervention of physiotherapists in primary health care for prevalent low-complexity MSDs, and the improvement in the efficiency of certain healthcare processes. I'm afraid it wouldn't be possible today to mention all the proposals, but if you wish, I'll show you later where you can find them. So there was another group that has worked to define a new model for healthcare in MSDs. The proposed model of health established by the master plan consists in promoting an integrated model for MSDs through action in 3 different fields. There is a first group of proposals that should be developed according to the new organization of health county governments that will enable all agents involved in MSDs in the same territory are better coordinated to achieve the best results. As you see, these proposals are shared objectives between different providers and healthcare levels, process management for prevalent diseases. There will have to be a territorial coordinator for MSDs in all these counties, and an increase in the detection in occupational diseases and improvement in the management of sick leaves related to MSDs. In a second level, the primary healthcare should strengthen support tools needed to improve professionals' problem-solving capacity and the coordination with specialized services, specifically through these measures: to involve nurses in health promotion, prevention, and control of MSDs in primary healthcare, to enable the access to physiotherapy from primary healthcare to MSDs, to elaborate diagnostic imaging protocols in primary healthcare, and to bring specialists closer to primary healthcare in order to provide support to the GPs. Finally, the proposed improvement at specialized level is to create MSDs system functional units that are considered as units that integrate the activity of different professionals, such as orthopedists, rheumatologists, physiotherapists, or pain clinic experts, that will have to work with shared clinical information, with coordination systems for complex cases, that will have to agree on a health service portfolio, with process management in shared pathologies, and in these units, the accessibility will be guaranteed to 15 days for some conditions, either because of their potential severity or because they are causing some kind of incapacity for work. So, in summary, these are the main features of the master plan. And finally, let me show you our website, the website of the Catalan Ministry of Health, where translations of the master plan into English and French will be available soon. We would be very pleased if we could have again the opportunity to come back to this conference in the future and explain a particular or a tangible result, and not only the good intentions we've talked about today. Thank you very much for your attention.